welcome back to The Explainer. Today we're diving straight into the surgical procedure for a heterotopic kidney transplant. We're going to break down this incredible, life-saving operation step by step, right from the initial anatomical planning all the way down to the final functional sutures, making the entire sequence crystal clear. Here's our surgical roadmap for today. 1. Introduction. 2. Phase 1. Anatomical placement. 3. Phase 2. Vascular anastomosis. And finally, 4. Phase 3. Urinary reconstruction. All right, let's jump right into Section 1. Introduction. Understanding the approach. Okay, before we make our first virtual incision, let's nail down what we mean by heterotopic. Basically, it means placing a donor organ in a totally different anatomical position than the original native organ. So when surgeons perform this transplant, they aren't just swapping out an old part for a new one in the exact same spot high up in the back. Instead, they are entirely relocating the operation, literally building a brand new home for the kidney. Moving right along to Phase 1, anatomical placement, specifically retroperitoneal exposure. Now, whenever we talk about heterotopic placement, there's this one major, kind of counterintuitive question that always pops up. What actually happens to the native kidneys? I mean, if you have a diseased, failing organ, the logical assumption is you got to take it out first, right? Well, actually, no. They remain completely intact within the retroperitoneum. The recipient gets to keep their original kidneys. Surgeons just leave them entirely alone unless there's a really specific, severe clinical reason to do otherwise. We're talking severe chronic infections, intractable hypertension, or maybe if a patient has severe ADPKD, where the cysts have made the native kidneys so massive there literally isn't enough physical space for the new one. But standard protocol, the old kidneys stay exactly where they are. So the old kidneys stay put. Where does the new one actually go? Well, step 1 involves an extraperitoneal approach using a Gibson incision down in the lower abdomen. Then, step 2 is the actual placement, usually in the right or left iliac fossa, which is essentially the lower pelvic region. The crucial point here is that the right iliac fossa is usually the go-to spot. Why? Well, because the right external iliac vein sits a bit more superficially and has a flatter orientation. It seems like a minor anatomical detail, but it's a huge deal in the OR because it makes the delicate vascular suturing we're about to talk about a whole lot easier. That brings us to Phase 2, vascular anastomosis, or reestablishing blood flow. Getting this arterial blood supply right is absolutely paramount. And it's fascinating because the surgical technique actually shifts depending on where the organ came from. Let's look at this comparison. If the kidney is from a deceased donor, surgeons use what's called a curl patch. Basically, this is a small piece of the donor's aorta right around the origin of the renal artery. They use this patch to make an end-to-side connection to the recipient's external iliac artery. This patch is a total game changer because it massively reduces the risk of renal artery stenosis, that dangerous narrowing. On the flip side, if we're dealing with a living donor kidney, surgeons typically just do a direct end-to-side anastomosis to the external iliac artery, or sometimes an end-to-end connection to the internal iliac artery. Grounding ourselves in the authoritative clinical standards here, we can see exactly how that venous connection is mandated. Once the vessels are isolated, the donor renal vein gets connected to the recipient's external iliac vein. To pull this off, surgeons use a running, non-absorbable monofilament suture, usually an incredibly fine 5-0 or 6-0 proline, in an end-to-side fashion. We're talking incredibly meticulous, exacting work. And you know, all that meticulous work leads to what is honestly one of the most incredible moments in modern medicine. Once both the venous and arterial connections are totally secure, they take the vascular clamps off. Immediate pink discoloration of the graft and palpable pulsations confirms successful reperfusion. Just imagine that moment in the OR. This pale, dormant organ is suddenly flooded with blood, flushing this vibrant pink color and literally pulsing with new life. It's the ultimate visual confirmation that Phase 2 is a success. All right, let's move into Phase 3, urinary reconstruction, establishing output. To really grasp this phase, we need to demystify a pretty formidable-sounding clinical term, ureteronosystemy. It's a bit of a mouthful, but the concept is actually super straightforward. It just means establishing urinary continuity by tunneling the donor ureter, the tube carrying urine out of the kidney, directly into the recipient's urinary bladder. This is the crucial anatomical bridge that lets filtered waste safely leave the body. So how do they build that bridge? The standard approach is the modified Lich-Gregor technique.
First, the ureter is sutured right to the bladder mucosa in an end-to-side anastomosis. But the real structural genius is the next step. The detrusor muscle, which is the thick muscle of the bladder wall, is actually closed over the newly attached ureter. By tunneling the ureter under the muscle like this, surgeons are essentially building a biological one-way valve on the fly. As the bladder fills and that muscle stretches, it compresses the tunnel, creating this natural anti-reflex mechanism. This completely stops urine from backing up and damaging the brand new kidney.
And that brings us to the final clinical step. A vital safety measure here is temporary stent placement. Specifically, a temporary double J or DJ ureteral stent is left inside that newly connected ureter. Why? Well, it maintains patency, basically keeping the plumbing propped open, protects those incredibly delicate, freshly sutured tissue edges, and minimizes any risk of early urinary leaks or strictures. It acts like a scaffolding, protecting the surgeon's work while the body heals up. And the best part, it's easily removed cystoscopically just a few weeks post-surgery. Wow, we've covered a tremendous amount of clinical ground today. But as we wrap up this explainer, I want to leave you with a final provocative thought. How does this precise three-phase sequence redefine our understanding of the human body's adaptability? Just think about it. We leave the old, failing organs completely in place. We meticulously route a brand new blood supply into the lower abdomen, totally bypassing the original architecture. And we literally construct new, functioning biological valves out of existing bladder muscle to protect the new organ. It's a breathtaking testament to human biological resilience and the insane precision of modern surgery. Thank you so much for joining me for this explainer. Keep questioning, keep analyzing, and keep learning.